Okay, well, welcome, ladies and gentlemen, to the March board, getting ahead of myself, of the Worcestershire Acute Hospital Trust. Delighted to have members of the public joining us, and also delighted that Ali Koldscombe, our new HR director, has joined us, and it's her first board with us. So, Ali, we wish you every success in your new role with us, and sure you're going to have a big impact. We've already had a busy morning today. We had a wonderful patient story about the way we were working with our colleagues in Hereford and Worcester Partnership Trust, supporting members of our community who have learning difficulties, particularly talking about the usefulness of the health passport. We then talked about the work on single access across the system, and then had a good session on our allied health professionals and all the great impact they're having within the acute and going forward, and then had a substantial session on our financial strategy and financial recovery. I would just like to assure members of the public and taxpayers in Worcestershire that the board are working very hard to ensure that we as a trust are as productive and as efficient as we can be. That will be coming as a new financial plan to the public forum next month. But one of the things which is reasonably heartening is when we compare ourselves to other hospital trusts of a similar size, we benchmark well in terms of our costs. So we do have a good trust which is solidly run, but we are ambitious and enthusiastic about the ability to go further in terms of productivity and even harder on our performance for those we serve. We are aware that members of the public are still suffering often very long waits in our A&E, and we apologise for that. As Stephen and Glenn will touch on, though, we are making progress on our cancer performance and elective recovery waiting times, but there's still an awful lot more to be done. So without further ado, any apologies for absence, Erica?
No, Chair. Although Julian has said that he will be popping in and out because he is in theatres as well.
Okay, so Julian is our joint CMO with Jules Walton. Julian's in theatre, which is where he's probably doing a lot more good than just listening to me with all. Any declarations of interest, please raise a digital hand. Okay, can't see any raised. The minutes of the meeting held on the 21st of December, were colleagues happy with the accuracy of those? If you weren't, could you please raise a digital hand? Okay, I'll take those as an accurate record therefore. And then our last board meeting was the Foundation Group 4 board meeting on the 7th of February. If you weren't happy with the accuracy of those, could you please raise a digital hand? Okay, so I'll take those as accurate also. The matters arising on the Foundation Group, I will take as ongoing as we're in between meetings. But on page 26 of our pack, we have the one action point arising in the December board, which was Tina to provide a timeline regarding job plans following discussion with executives, and that's been done. So thank you in abstention, Tina. Are there any matters arising colleagues feel I have missed? Okay, so I've covered the board workshop update, so we'll move on then to Glenn's Chief Executive report. Glenn, how are you seeing things?
Thank you, Chairman. A few things to draw out of my report. I'll take it as read, but I start with the financial position that you just touched on at the start there. We obviously spent quite a bit of time this morning in workshop talking through the components of that. Obviously, we this year will have a 35 million circa deficit, and if you take that into next year with some of the additional costs that we face, such as the new ED and the additional wards that were agreed as part of winter, you then unfortunately have to add to that a £42 million non-recurrent income that the trust received this year. So you're already above 75 million there as a start point. So that puts us in a position where we need to go into financial recovery mode, and I described some of that here. We set up a financial recovery board. We are developing the plan, and that's what we discussed this morning. And it's got three main elements to it. There's a PFI element to our cost base, which we are reviewing now, but obviously runs for another 7 years in totality. There's then a demand-related element to our financial position, which is based on mainly urgent care activity because it's contained within block contract these days. So there's no extra income associated with that. So we'll be working with system partners to seek to reduce the demand or come up with an alternative strategy for covering the costs of it. And then finally, a productivity related element, which is absolutely for us to focus on as an organisation. There's an opportunity now with the way the elective recovery fund works for us to do more elective activity and generate more income, and to take the margin that provides into our bottom line, which is absolutely a great way of achieving financial recovery. So we'll focus on that. And then also looking at cost out. One of the biggest drivers for that, generally across the NHS, but certainly the case for us, is around temporary labour costs, where we've increased headcount over the last few years, and we need to now control agency and locum spend. So as you said at the start, Chairman, we'll bring that plan back into our public board meeting next time. Meanwhile, we're working on the details of that. And one thing that's not helping is the lack of national planning guidance. So usually at this point in the year, we have planning guidance, and with 19 days left in this financial year, we haven't received that yet. Obviously, there are elements of the budget last week which will have a bearing on it, and we understand that we will get final guidance this week. We've seen some drafts, and that's allowed us to pull together some plans. And regardless of whether we've agreed a financial recovery plan with NHS England, we absolutely need to ensure we start this year with a clear set of budgets within the organisation. We'll be doing that. The other element that affects our system is a new rule around repayment of previous deficits. There will be an element of funding that will have to be used to repay previous year's deficits in our system. I then move on to British Association of Dermatologists report. That this follows the collapse of the service earlier on in this financial year. It wasn't an independent investigation. It was carried out by the British Association of Dermatologists and therefore focused on the views of the dermatology team. But those views are really important. And what the report has helped us to look at more fully has been how we could have avoided the situation and how we need to now rebuild a dermatology service for the local community moving forward. We're doing that in partnership with our Wye Valley colleagues, group colleagues there. They will be the lead provider of the service, and those plans are coming together, and obviously we will continue to ensure that there's local access to dermatology. But we do need to ensure that, particularly as a board, we set the tone of the culture within the organisation. I strongly believe that the best teams have self-regulating cultures in that they support each other and challenge each other. But occasionally we need to provide support or step in and take some action, and we'll be ensuring that we do that as an organisation in the future. We're also doing some work across the group, which I reference here, on what's called Civility Saves Lives, which looks at the impact that the relationship between team members can have on poor outcomes for patients, and just points to civility as being a way to ensure that everyone has a positive attitude. And we'll be looking at rolling that into Worcester Acute, which is in the process of developing some online learning tools and supporting individual teams to do that. So we'll be doing that here. There's elements of the 10-point plan that also play a part in helping us to recover the situation. But we need to listen to our staff, and we need to act on what they say. And so the report's really helpful in that regard. And we'll discuss that more in our private session. So I then refer to the March target around A&E performance. It will be a challenge for us to step up to 76%, but you'll hear in a moment from Helen and colleagues some of the improvements that we've seen in our urgent care pathway over the last couple of months or so. We've certainly improved ambulance handovers, and we've certainly improved our A&E performance. And obviously there's more improvements to come, and some of the things that we saw earlier today around single point of access are certainly going to contribute to that. I then referenced the strike action. We still haven't had a resolution to the junior doctor strike, and I hope that comes soon, because patients will be harmed, because any delay to treatment potentially can harm the patients. So the sooner we get a resolution, the better. There's a reference change to the board, and welcome Ali today. We also talk then about the work of a couple of great teams, digital team and the nutrition and dietetics team. And I won't go through all of those, but you can see some of the innovation and change that's going on. Just returning to digital, one of the announcements that was in the budget is some additional funding to address productivity using technology. So with Vicky and team, I'm sure we'll be trying to ensure that we can access some of that funding to help us with the productivity challenges I started with at the start of my report. Happy to take any questions, Chair.
Thank you, Glenn. And I would just like to add my thanks to the British Association of Dermatologists for their hard work on undertaking that piece of work. Any questions or perspectives to Glenn? Richard?
Thanks, Chair, and thanks, Glenn, also. I really like the style and the openness of the report, Glenn. I think that's really good. You made a few remarks about the culture. It'd be great if we can come back to that point in the board in the near future, because I think that's really one of the key actions, key learnings we need to take from the dermatology report. But I also wanted to kind of confirm the spotlight that you put on the digital team. And I think we've seen some great things over the past years. Yesterday, as non-execs, we did a visit in the Alexandra Hospital. And it was really mentioned several times by people that were involved in different departments in the flow, that this is really helping them practically. So I was just going to say, it's not just a digital program, it is really making a difference to the daily work of the people.
Yeah, thank you for that, Richard. I completely agree. Done really well. Digital solutions can help with all sorts of aspects of the patient care, but also the productivity of the organisation, and making best use of the spare specialist clinicians that we have is really key in all of that. And I agree with you in terms of culture. We will spend quite a bit of time on this. We need to get under the bonnet of the National Staff Survey results, which point to areas of the organisation where we could improve our relationships with the workforce. And for me, it's about ensuring that our workforce are empowered. The biggest indicator to me actually is we had a very low response rate to the staff survey, which implies a feeling that we're not going to listen to our staff. So I'd like that to really increase, and I'd like all of our staff, particularly those listening to this board meeting, to feel that they can put their points forward and they're going to be acted on.
Absolutely, our staff are our most precious resource and absolutely determined our effectiveness as an organisation. Any other questions to Glenn? Otherwise, we'll move into the detail of the integrated performance report. Okay, so Stephen, over to you.
Thanks, and this will pull up certainly some of the things that Glenn has mentioned, and I won't go into a lot of detail because others do that in their section, but just to give an overall view. I think if we start with urgent and emergency care, we will touch on the work that we're doing around March and the 76%. But as a reflection, we have seen increased attendances compared to the same period last year. I would point out for things like the emergency standard, they're probably the lag indicator that will move once you've done all the other things and you see the improvements working through the department. So particularly the focus that we've had for ambulance handovers. In this month, we've seen the live data and that has reduced dramatically, although I will say we still have spikes, particularly at weekends and out of hours, where it may be a lot smaller numbers, but it's still far too long a delay in terms of ambulance handovers. But the teams are really kind of embracing the March challenge around the 76%. And particularly our non-admitted and minors performance is showing a substantial improvement, which is really something that we've got to go on. key for Helen and I will be, and the organisation, is pulling out the themes of what's sustainable with that when you're and how that drives improvements going forward. We haven't seen that improvement in length of stay, which is still too high at 8.6 days. But the bit I would caveat that bit when you read the quality section is around some of the IPC outbreaks we've had as well. So actually, we've been trying to drive at those performances with around 20 beds less on the Worcester Royal site, because of the loss of those beds to infection control. There's been a particular focus around our cancer performance, and in particular the number of patients that have been waiting over 62 days. Cancer's a difficult one through the performance report because of the lag, but actually if we looked at last week and month end, there's a significant improvement, and I'm sure Helen will mention it and I won't steal her thunder on that one. And equally, we've got a challenge around our 78-week position, which I think last month was looking particularly challenging in terms of the numbers of patients that look like they will be waiting over 78 weeks. And the division has undertaken an enormous amount of work, and that looks well on a trajectory to be under the 40 from well over 150 before. So I think there's significant work that will reflect back in future reports. Just to touch on some other areas, and they all kind of link to that finance, the performance and the quality bit, is around the workforce. And what we have seen is that increase in workforce substantively, which should have an impact on our agency. Although I think it's fair to say we're not quite translating that yet because of things like sickness and the unplanned capacity that we've got up. A key bit for us in the planning for next year is where we've got additional areas, making decisions quickly on substantively recruiting to those areas so that we can switch that mix of workforce. But undoubtedly, there is an awful lot to do for us around better management of unplanned workforce needs, I would say, and that will drive both quality and financially. And the finances have been mentioned, so we've shown the deficit position there of 27 million, leading to where we think we'll be at the year end, and we've set before to board at 36.6 million. So that's kind of the overall summary. They're all threaded together, they're all there. I think the key thing for us in that planning is we need to sort out flow, and predominantly that will be frailty and general medicine, and then a really significant bit around productivity, which will produce the cancer and the elective targets that we need to hit. And then finally, that bit around agency workforce and really having a look at and being quite disciplined on recruitment, but also how we manage unplanned need through the trust. So Russell, I'll hand over, if that's okay, to the quality section.
No, that's great. Actually, the operational section is next in my pack. So okay. Can we do that first, Steve? Thank you for that clarity of focus. So we'll go into Helen, and Helen, over to you.
Thank you, Russell, and thank you, Stephen, and thank you for not stealing my thunder. That's lovely. I will take the operational performance part of the report as read, but I just wanted to pull out some of the key highlights, as Stephen has said. So we are beginning to, and whilst this is January's data that we are looking at, as we move closer towards the end of the year, we're starting to see some improvements across all of the performance metrics on the backdrop of a challenging winter period. So we did see our attendances compared to last year through the ED on both sites increased by 13.3%, which is about 50 patients a day. And whilst you might not think that number is a huge number, it does impact on the waiting times within ED. We've also seen an increase in our long length of stay. So that's those patients that are waiting over 7, 14 and 21 days. And that again then is increasing our length of stay across the organisation, which again makes that a challenge for us in terms of the flow. But on a positive note, what we have seen is a significant increase in the amount of activity that's going through our same-day emergency care unit, which at the moment is situated within the old ED, and those of you that have visited there will know that that's multi-specialty. So we have the surgical SDECs, medical, and the cardiology SDEC working through there, and that's where patients can be seen really quite quickly if they need to come back for an investigation or a procedure. They can be seen and turned around in a day, and we've seen some really great work going through there. What we have also seen is a reduction of 8% in the number of our long ambulance handover delays, and that can only be a benefit not only for patients but also for the staff as well, in terms of how they're trying to pull patients quicker into the ED footprint. Now, all of that urgent and emergency care work is underpinned by a big transformation programme that the board heard an element of that this morning around our single point of access work, where we are looking at how we can stop patients attending unnecessarily the emergency departments and actually accessing the care that they need from a different place or through a different area of the organisation. But that piece of work is also looking at our processes at ward level, and also about how we can improve discharges and speed up our discharge process and reduce the length of stay for patients in the organisation. So it's a big piece of work happening at the front door, our internal processes, and then how we support patients being discharged in a timely way. And so we are starting to see the benefits of those as we move into March's data. As Glenn has mentioned, and both Stephen has mentioned, our drive to improve our EAS standard during March, and so we've affectionately called it our super month. And so this is the opportunity for us to test a number of things rapidly, to see what works and what doesn't work. And there's a huge amount of work happening at the front door around rapid streaming and rapid triaging, again maximising the opportunities through our same-day emergency care units, and looking at what the staffing levels look like and the different types of staff that we have at different points of the day. So I'm going to move on then from urgent and emergency care and talk about cancer. And cancer, as you know, for some time across the organisation has been particularly challenged. We had a number of fragile services, and we've mentioned dermatology being one of them, the other one being urology. But again, we are now starting to see the improvements through there, and our 62-day cancer backlog has significantly reduced. And as of today, it has reduced by over the last I think we were 399 in December, and we are now looking at 226. So really good progress on the 62-day cancer performance, and also an improvement across our faster diagnosis standards. So that's how quickly patients are told whether they have cancer or not. So I think it's watch this space as that activity and the performance starts to come through. And then the final thing that I wanted to talk around as we race towards the end of the year is about reducing the long waits within the waiting list, and our drive to get to zero for those patients waiting over 78 weeks. And I think it's fair to say that the organisation is unlikely to deliver the zero at the end of March, but what we are aiming for is around circa 20-25 patients that will breach 78 weeks at the end of March. But our ambition then is for that to be zero, and we will have peaks and troughs, and we will have some challenges as the year moves on. But again, we're striving really hard to keep that at zero. Then, while we work towards reducing the numbers of patients that are waiting 65 weeks, and that we aim for that to be zero by September. So there's a lot of detail in the report, and so I'll just take any questions, Russell.
Thank you, Helen, and thank you and your team for your hard work. Any questions or perspectives to Helen? Tony?
Yes, thanks, Chair. Helen, it's in relation to the faster diagnosis on cancer, 28-day. You referred to the challenge services in skin and neurology, which we've talked about to some extent recently. I wonder if you could just comment on haematology, which also seems to have a challenge in terms of its performance on that measure, please. Thank you.
Yes, thanks, Tony. And the difficulty that we have with haematology is that there are often small numbers of patients through that pathway, and many of the haematology patients go through a number of other specialties before they end up within haematology. And so if you've got, say, 10 patients that have gone through and have gone through other specialties, and then it makes you only need 1 or 2 then to not hit the 28 days before they breach that target. Now, haematology is one of the tumour sites as such that we are seeing some improvements now as we start to move forward. In fact, all of the tumour sites are now starting to see significant improvements as we go into the end of February and March data. So I'm confident that we will get in a better place across all of those tumour sites.
Thanks, Tony. Thank you, Helen. And Colin?
My question's around the single point of access. We had a really interesting description of the way in which this project is being developed. Sounds like a great example of multi-partner working. Do you think we've reached our potential, or is there more to do to get an even better impact?
Yeah, thank you, Colin. That's a really great question, and I think there is definitely more to do. We're still quite early days in relation to that. I think we started in December, so it takes a while for us to get up and running. I think there is more opportunity around widening the access to the single point of access, and at the moment that's through health professionals and care homes, but there may be an opportunity in the future to some of that to be open to patients so that then they can contact the single point of access rather than them having to go via 111 or via their GPs. We've also more access for some of the community staff as well. So I think there's a greater opportunity. We want to embed the service that we've currently got there before we move on to the next step.
Thank you, Colin. Thank you, Helen. Keep up the strong work, and fingers crossed for the end of March. We'll move on then to the quality and safety bit of our report. Julian, thank you for joining us. See you're suited and booted. And Liz, thank you. Alison, thank you for standing in for Sarah. Alison, do you want to lead us off?
Yeah, thank you, Chair. The only escalations I wanted to point out from quality and safety perspective were the continued number of outbreaks we have with COVID, still stabilising at around 50 patients across the trust for a number of months now. However, we are still adhering to national guidance around testing and isolation for those patients. But as Helen has already alluded to, that does add and contribute to our length of stay in terms of discharging these patients from our organisation, particularly when they go to community hospitals. We've had an enhanced IPC risk assessment completed on Aconbury 0 due to some environmental concerns, and we've had the support of NHSE with that, which we've welcomed, and we've purchased some red air units to improve the air quality. Aconbury 0 is now open fully and in use. The other issue I just wanted to mention was around our complaints compliance, and we've got continued monitoring with our overdue complaints within division, and we're reducing those, particularly within surgery and within children's. Thank you, Chair.
Thank you, Alison. We'll move on to Jules and Julian just before I invite questions. Jules and Julian, anything you want to add in terms of quality and safety?
From my perspective, no, thank you, Chair. Said the report will take as read. There were a couple of items that, for reasons which I won't complicate things with, didn't make onto the report this time, but just to assure board, in terms of our mortality indices, they're all still within range, which we've been reporting now for a few months. We have highlighted previously that we'd got some concerns about sepsis reporting, so our sepsis screening reporting has been a challenge just in the transfer across to the digital collection of that information. So we're conducting a spot audit, I suppose, if you like, just to give assurance around that while we're waiting for the fix to go in place to maintain that data integrity. And our fractured neck of femur compliance still remains challenged, of which there is more work ongoing in order to bring that up to the standard we would expect for our patients.
Thank you, Jules. Julian, anything you want to add?
Nothing in addition to the report, Chair. Thank you.
Thank you, Julian. So questions and perspectives, so just keeping the pace going. Glenn?
Yeah, thank you, Chair. I just want to pick up with Alison on the 25-day complaint response target. I mean, firstly, I would rather we fully investigated and fully learned from complaints rather than necessarily get them answered rapidly. Ideally, we answer them rapidly, but I think the learning and the fullness of the investigation is most important. But we do need to make sure we're keeping communication lines going with the complainant if we're beyond that 25 days. I assume that's the case.
Yes, Glenn, thank you. And the internal target is something that we have set ourselves within responding within 25 days. But absolutely do also advise our divisions or encourage our divisions to contact the patient or relative, whoever's made that complaint, within 24 hours, 48 hours of that us receiving that complaint through to the divisions, so that we can firstly identify what they would like us answered in their complaint. So we're absolutely drilling down to the detail, but also that we keep them advised of the time frame.
Thank you, Alison. And Simon?
Thanks, Russell. Alison, are our partners at Health and Care Trust following the same national guidelines on IPC that we do? I know historically there has been a difference, which has resulted in patients being kept in our beds longer than perhaps they should have done. So I just wonder where we are with that.
Yeah, thank you, Simon. It is still slightly different. And I think, you know, the Health and Care Trust, particularly the community hospitals, do advise that as soon as a patient is discharged from our acute area, that they go into a side room. So that does create some delays in discharge from our hospital, but that is obviously just to keep their COVID numbers down and any risk of spread. So we absolutely do understand their reticence around that frail elderly population and why they wouldn't want to increase any risk of infection within their areas.
Okay.
Could I just come back on that, Russell, please?
Yeah.
Because we're all supposed to be following the same national guidelines. And I do understand their concerns, but they are the national guidelines, and it is leaving risk with us or leaving patients with us who are a longer length of stay than they should otherwise have. And I speak from personal experience. Colleagues will know that I've had an elderly relative in the hospital before who was held back for 5 days because he had COVID, yet he'd passed our IPC standards, which are the national guidelines. So I'm not sure whether we should be pushing back more on this.
I think that's a good challenge, Simon. Alison, can I ask you to ask Sarah to take that forward with a colleague in the Partnership Trust? Thank you. Karen?
Thank you, Chair. I wanted to come back to complaints, I'm afraid, and just pick up well, firstly, acknowledging the improvements that have been made, because you can see that the backlog has reduced. However, on page, I've got several page numbers, page 46 of 224, it does talk about the improvements that were made in surgery. However, also says that that is now doubled in 1 month because the additional temporary resource that had been put in to support the reduction of the backlog, one assumes has now been withdrawn or moved on. But I'm looking for some assurance that we're not going to see that creeping up again now that resource is there, because I fear that we're going back into the backlog situation.
Alison?
Yeah, thank you, Karen. And I think, you know, that's an absolutely valid point to make. So we've been working really hard with the surgical division and not only the nursing teams, but all the operational and clinical team with regard to getting those complaints answered really, really quickly. So we have been working on not only their backlog, but also the complaints that come in live. So there's almost 2 work streams running alongside to ensure they're not breaching. And I think it's almost becoming business as usual. So rather than them becoming used to that increased level of support, which obviously they did need initially, for them to developing a process and getting that well embedded within their divisional work to ensure they're handling those complaints on a regular basis. And we are getting there, and we're monitoring very, very closely. Not only through their divisional governance processes, but through our corporate governance as well.
Let's keep an eye on that, both the board and the F&Ps as well. And finally, Tony, then we'll move on.
Yeah, thanks, Peter. Can I come back to the sepsis item, because we've raised that as a concern previously here. Just the timeline for when you think the reporting should be back on track, please. Thank you.
Jules?
I can't give an actual time, Chair, at the moment. I'll have to check back in with the digital team, because they're working on it in conjunction with our EPL colleagues as well. But I'll find out and get back to you.
Okay, let's make sure we pop that onto the action points, Tony, and then we'll follow it up next one. Okay, Tim, we're running a bit behind now, so if we can ask colleagues to pick up the pace, that would be wonderful. Liz, thank you, Liz Faulkner. Thank you for leading on our workforce. What would you care to pull out of the report?
Thanks, Chair. So I think a really good news story is our continued reduction in our vacancies. We've seen a month-on-month reduction, and our January position of 7.6% vacancy rate compares to the last year's 11.9%. It really shows that huge reduction we've seen in our vacancy rate. Unfortunately, as Stephen alluded to, though, the temporary staffing spend hasn't reduced in that same way, and particularly agency spend remains a significant challenge. We know that some of that will be due to the winter wards and sickness, but we need to really unpick why we're not seeing that corresponding reduction as we would expect as that vacancies reduce. So that's going to be a big challenge for us to look into over the coming months. Our staff turnover has remained below our target, which is good. So our current position is 11.03%, below our target of 11.5%. So it's great that we're managing to keep our staff, but that we really need to make sure that continues in the coming months. Sickness absence, even though we know there's a seasonable peak in December and January, that our sickness levels remain very high, and particularly of concern is the number of stress and anxiety types of sickness absence. So work into the coming financial year, this will be a big factor to be looked at by the HR business partners and the HR advisory teams, along with operational colleagues, to make sure that we're managing the sickness robustly, but also giving staff the health and wellbeing support that they'll need to support them with their particularly the stress related absence. Consultant job planning has dropped again a little bit this month. We are in a position now where we've agreed our new job planning policy in January with staff side, which is very positive, and we're linking in with colleagues at Swift who are going to support us with some training around that new job planning policy. So we all are expecting to see those numbers of job plans completed and up to date increase over the coming months. And finally, mandatory training, we've seen a pickup in terms of our compliance. So we're currently at target of 90%, which is a positive position. Happy to take any questions.
Thank you, Liz. Questions and perspectives, Karen?
Thank you, Chair. Thank you, Liz. Well done on the vacancy rate. As you say, I've seen lots of information about all the recruitment activity that's taken place. So well done to you and the operational teams on that. I wanted to pick up on sickness absence, and it's possibly to say, Chair, that I'd like to take it back through to People Committee, because a number of times, both here and in the report and elsewhere, it's mentioned that it's one of the impacts on our bank and agency spend. And my understanding is, and I appreciate that this doesn't cover every single post, but that we have quite a generous allowance built in for sickness, annual leave, training. I've got 21% in my head in total. I may be wrong on that. But I know that there isn't a built-in allowance for sickness, which says to me that we wouldn't necessarily be covering sickness with bank and agency. So I'd not necessarily to follow up now, but I think it's something I'd like to look at in more detail at People Committee.
That would be great, Karen, because one of my anxieties, just Liz, educate me quickly, on the medical and dental line, who are we defining as medical and dental? On the sickness absence descriptors. Liz, do you happen to know who we're defining as medical and dental?
Sorry, Chair, my Wi-Fi just dropped out a bit there. Can you just repeat that question? Sorry.
That's okay. On the sickness absence chart, we've got medical and dental. Who are medical and dental? Just for the avoidance of doubt.
So medical and dental is all of our medical staff that would be from our doctoring training, our trust employed doctors and our consultant body, and any dentists that we employ, which small numbers, but that would be part of that group.
Okay, so I'm not going to comment on the other lines on that chart, but I would just like to thank our medical and dental colleagues for their exceptionally low and consistently low level of sickness and absence. Karen, I think it'd be great if the People Committee did a deep dive into the issues going on there. And Richard, then we'll move on because we are running late.
Thanks, Ursula, and thanks, Liz. Liz, like Karen said, great progress on the vacancy rate, but I know you're stepping in here. I need to be a little bit critical. We don't see it translated, let's say, in bank and agency, and you said you don't really understand it and you need a couple of months to find out. I think that is really not acceptable with making the plan for next year. So can I urge us to find out sooner and really get into the detail of this?
Absolutely, Richard. So we'll leave that, Stephen, under your auspices, but you take the flavour because it builds on some of the comments we made earlier in the financial strategy session as a board. Glenn, your hand went up and then went down. Are you okay? Okay, super. So Neil, we've had a big session on the finances this morning. What would you care to pull out?
Yeah, thank you very much, Chair. So month 10, we returned a deficit, an in-month deficit of £5.6 million, resulting in a cumulative deficit of 27 million. That 5.6 million in-month deficit is a deterioration in the run rate of 0.7 million compared to month 9. We had largely expected that. We're in the height of winter, obviously, we got additional capacity open and we had bank holidays in December. So we had expected a deterioration in that in-month bottom line deficit. And indeed, what we had previously forecast in submission to board back in December, our month 10 deficit of 5.6 million, we're £500,000 ahead of that in terms of that in-month forecast. That brings us to 0.8 million better than we had forecast at the start of the year. I would like to point out, however, and you'll see in the pack, there is an additional £1.6 million of risk in respect of payment for the Urgent Emergency Care Centre, currently under discussion with our ICB colleagues. I am confident that we'll get to a position of an agreement that doesn't place at risk our overall £36.6 million deficit for the year, Chair. Happy to take any questions. Thank you.
Thank you, Neil. I know there's a lot going on in the finance team at the moment. Any questions or perspectives to Neil? Okay, team, we are running about 20 minutes late, so we'll move on then to the perinatal safety report. Justine, over to you. Lovely to see you.
Thank you, Chair. So I will be brief then. So this is a safety report for January. So generally I'll take the paper as well, but just want to highlight a couple of things as I go through the paper. So good news is that the booking by 12 plus 6 weeks is really starting to increase consistently now, and we continue to work with our digital colleagues to improve the quality of that data, which has been really helpful in demonstrating our actual performance. The workforce KPIs, you'll see that generally it's an improving picture with midwives, but unfortunately a slightly decreasing picture with our maternity care assistants. Pleased to report, having seen February's data already, that is now an improving picture overall for both groups, so that's really good news. Training, you'll see that we're meeting our trajectories, and where compliance isn't yet met, we are on the upward trend for our training, and we have, due to our generally slightly increased staffing position, been able to support all of our mandatory training that we need to do role specific wise for the last month again, which is great. Sadly, we reported 2 stillbirths and neonatal death in January, and we also had 2 new cases that we reported to MNSI that you'll see, and we'll discuss obviously in greater detail in private. There are 10 moderate harm incidents you'll see there also, which have that are now either being locally investigated with MNSI, as I've said, or have got local reviews, rapid reviews or after action reviews. You'll see there are some mitigations within the report because of some reduction in our medical staffing posts, but we did also recruit 2 new consultants, which is great news. In terms of recruitment, while I'm talking about it, we've got 16 new MCAs in the pipeline. So that red position for MCAs will change quite considerably over the next 2 months. And all the midwives that we were expecting to arrive in February and March have arrived now. So again, a much more improved position there from the recruitment that we're doing. We achieved 100% attendance for the consultants, which is a really great indicator of safety. You'll see that the PICA report for last year is now available after being embargoed for some time, and we'll provide a summary report in the next month's board report. But overall, there doesn't seem to be a huge amount of change, and a lot of the actions that you'll see in the PICA report action plan within the pack won't really show great changes until probably the survey that we're currently completing, because lots of those were put in place at the back end of last year. 2 formal complaints, and that's a reduction in our complaints, which is great news, and an increase in PALs. The MSSP exit criteria, as you know, we've reported here before, has been met, and we're just waiting for all the formalities, various committees that need to see that sustainability plan agree, and then hopefully it'll be April when we get our formal notification of exits. That's great news. BNSP, as you know, we submitted our declaration form for 9 out of 10 with our associated action plan at the end of January. They have come back to me wanting a little bit more information around the request for funding around the One Action. We've provided that, and we hope to hear quite soon. The next scheme, Year 6 scheme, should be available in April, and we've already been given some indications that it will be made a little bit easier for us next year with not a huge amount of changes to Year 5 schemes. So we've already got all of that in train, which is good. I just finally want to just draw your attention to a divergence from the Saving Babies Lives care bundle that we have to note here at board, and that's around PIGF testing, as opposed to we are currently providing home blood pressure monitoring as an alternative. Obviously, within the care bundle, it's suggesting that PIGF testing should be used, but you'll see there a long discussion and a full appraisal that has been undertaken by the clinical staff, and why we've come to the decision that home blood pressure monitoring is the better option and the safer option and the more supportive option for women with hypertensive disease in pregnancy, preeclampsia and pre-existing essential hypertension. So just there for your noting, and I'll pause there and take any questions.
Thanks. Thank you, Justine, and our heart goes out to those who have lost babies over the last periods with us. Any questions or perspectives to Justine? We duly note that issue on the home pressure monitoring. Simon?
Just to note, I would thank the efforts that have been made by the chaplaincy service and our bereavement services to organise gatherings, 3, one in each hospital area for parents who have lost babies. They're spread out over the year, and I think that's a commendable effort on their behalf, and I'm sure will be welcomed by those parents. Not out of mind is what it's called.
Yeah, no, absolutely. Well said, Simon. Thank you, Justine. Send our regards to the team. Immensely proud of our maternity team and perinatal team. Staffing reports. Back with you, Alison.
Thank you, Chair. Just very briefly, because of time, just to point out there's been a continued improvement in the reduction in agency spend, vacancy rates and attrition numbers for both registered nurses and healthcare support workers. But the additional capacity surge beds that were opened obviously in December has continued, along with the additional capacity and high acuity in ED, leading to a temporary workforce demand. But obviously we've continued with that due to patient safety in those areas, but nothing else to escalate with regards to the staffing.
Okay, thank you, Alison. And I'll just cover off, Justine, anything you wanted to add on the midwifery safe staffing report?
Just a couple of things. Obviously, we've just talked about the improving vacancy position. It's just a sickness absence, just to provide assurance that the kind of decreasing trend continues in February, which is good news. That pipeline we talked about is ongoing, and we're about to go back out to recruit hopefully our September students who qualify then. Within the report is that time of year where we have to do the 6 monthly birth rate plus tabletop exercise, and you'll see that they're described in the report. We are well funded for our maternity establishment, and therefore no additional funding is required this year to support that. One really point of celebration, which is I would be very remiss if I didn't mention it here. We had 2 internationally recruited midwives who have now completed their OSCEs and will be joining the team very, very soon. So we're really pleased that we've been able to support them through their OSCEs, and a huge well done to them.
Thank you. Any questions to Ali and Justine on the safe staffing report? Simon?
Alison, just a little bit more detail on that second sentence in the first paragraph of section 3 at the beginning, which refers to a correlation between staffing incidents and patient harm. How much attention should we be paying to that? What in actual fact does that mean in terms of implications for patients, please?
Sorry, Simon, if that wasn't clear enough, we'll ensure that that's written correctly on the next paper. No, we try and correlate any staffing incidents where we know we've perhaps got short-term sickness, for example, against any patient-related harm incidents, and there have been none.
Okay, Jules, did you want to come in on that? Okay, fine. Okay, thank you, Alison. Thank you, Justine. We'll move on then to some items for approval. I always find it somewhat mysterious when we sign off annually the going concern basis of a trust which is in deficit as much as we are. Slight juxtaposition for me. So, Neil, tell us what you want to on this, and then we'll duly approve.
Yeah, thank you, Chair. We're required to sign off the annual governance, the going concern paper, sorry. This has been to the audit committee. I've presented this paper and the details within as to why I believe we're still a going concern. We are supported from a cash perspective by NHS England. Indeed, we have recently been in this month. We are working on a 5-year financial strategy, or the strategy going forward, as we discussed in the board this morning, Chair. So I'm recommending to the board to approve the paper and confirm that we are operating as a going concern into the final accounts into 24-25.
Okay, great. And as chair of the audit committee, anything you'd like to add or brief us on? Okay.
No, thank you. Chair, we did go through this in some depth at audit and assurance, and it's more of a technical issue than a practical issue, I think, from our viewpoint.
Yeah, no, absolutely. Any questions or perspectives from colleagues? If you're not happy to approve, please raise the digital hand. Duly approved. So thank you. So the risk management framework and policy. Stephen, in Sarah's absence, are you going to handle this?
If I can get off mute, yeah, absolutely. So I'm happy to take the papers as read, and we can take any questions. We have done underneath the subcommittees, we have done a bit of refocusing around this. Particularly Sarah chairs a risk management committee now, risk management group within the trust that the divisions play into. So it's feeling like that's much more robust, reflected in the framework and policy. Happy to take any questions.
Great, thank you, Stephen. Any questions or perspectives to Stephen? So.
Sorry, Stephen, being a really picky so-and-so. Page it's moved, hasn't it, since yesterday? It's now page 154. We've got our greater thans and our less thans around the wrong way in a few places.
Okay.
Requiring time off for work for greater than 7 days in minor, for instance, when actually it moves into greater than 7 days. Sorry to be picky, but it's.
Oh no, I like
it.
Well, I've got another picky later on, so.
The details count. Richard?
Yeah, two things really. One is, so Stephen, can you just explain how this is going to be better than what we had? Because we are not just changing for changing, and I feel, risk management is really the responsibility of the executive team in the first place. So I'd be interested in what makes this better. The second thing is the CEO is called an accounting officer. Now, I know Glenn's background, but it needs to be accountable officer, I think.
Yeah, I think in terms of what makes it better, I think how we implement this, and particularly that focus on risk and those that are long-standing and the actions that we're doing. So if I reflect the last risk group that I was out with, Erica and Sarah, there was a real focus on what are your highest risks? Are they consistent across the divisions? So is everybody scoring it in a similar way? Because that with these things is always a slight issue. And being challenging as a trust, where we've got long-standing issues, have we got the controls in place, and are we doing the actions that actually reduces it, and really driving at that? So I would say, if I could pick out two things, they're the ones: consistency across all, and making absolutely sure that if we've got a long-standing issue, we're actually addressing it.
Okay, I think just building on Richard's point, Stephen, clearly it's key for you as an MD to drive it, and yeah. I've always seen Glenn as the accountable and accounting officer in my experience, Richard, so I think it works both ways. Okay, we'll move on then. So if you're not happy to approve the risk management framework and policy, could you please raise a digital hand? Okay, duly approved. Thank you, colleagues. So we're then on to the BAF and risk appetite. All of this is coming together at the moment, so to speak. Erica, but over to you.
Thank you. I think one of the reasons around the new risk strategy and framework as well was in response to an audit report, which I know the Chair of Audit and Assurance sort of draws out in his report later on. So alongside the policy, revising the policy and framework was a requirement to review the BAF. This is the proposed BAF for 24-25, and it very much focuses on the risks to us achieving our strategic objectives, to us achieving the 10-point plan. We've determined what the existing controls are in place and how we might get the assurances that those controls are working, but key of which are the gaps in controls and the actions of how we reduce those risks going forward in order that they don't impact on the 10-point plan. So there is further work to do to develop those actions linked in with the objectives. The old BAF risks haven't gone away. We've not just deleted them. The old BAF risks where there is still a risk will be captured on Datex, and if they still remain high risks, the board will still get visibility of those operational and divisional risks as well as the BAF. And then with the risk appetite, the board members will recall they had a questionnaire and it was all in order to determine the collective risk appetite of the board. This is the summary. It very much follows the ICB's risk appetite format, and it allows teams to be informed who are submitting business cases or when we're developing objectives to know what your collective risk appetite is going forward. The reason we've done it on the ICB approach is that we can see as a system where we may be more risk averse than in other areas.
Thank you very much, Erica. Any questions or perspectives to Erica on the BAF and the risk appetite? Karen?
Thank you, Chair. Thank you, Erica. First of all, acknowledging how tricky and difficult these things are to pull together, and it's always easy to try and wordsmith them after somebody else has done all the work of putting all of these words on a piece of paper. But just a couple of things, and I guess it's a note of caution really more than anything else in my mind about the wording, and I'm particularly looking at risk 5474 and 5475. The first one is about culture, and we know and we acknowledge, and we've already talked about it here, that we understand we've got quite a bit of work to do on culture. The specific linking to communicating the forward improvement system, I don't particularly understand how communicating that any better is actually going to help us, or worse for that matter, is actually going to help us change culture. So there's just something there as an observation. I guess more importantly, it was the next one, 5475, which talks about staff health and well-being quite appropriately, talks about some of the challenges, but also refers to a risk relating to workload. If you look at the risk description, yet all of the controls and assurance relate to us providing appropriate health and well-being support. And for me, it left a question in my mind. Well, are we saying that the workload is inappropriate and too high for some people? And if it is, then we need to have something in the controls that addresses that. Or if it isn't, I think we need to find a different way to describe it, because these are the sorts of things that get you in trouble further down the line. If that doesn't make sense, I'm happy to take it offline, Chair, but those were the things that I thought didn't sit well for me.
Okay. Voice of experience there, Karen. Thank you. Erica, do you want to quickly come in?
Yeah, very much. I need to take these BAF risks will be very new to our new chief people officer, so I'll take your points, Karen, and go through them. But I acknowledge it's a live document. It should be dynamic. It should be changing. Once we've got those risk descriptions, we can tailor the controls. The controls and the gaps and the assurances should be moving as we go through the year anyway. So I'll address those issues.
Thank you. And Sue, and then we'll move on.
Sorry, I'm being a nag again, but I brought this up before. The Equality Impact Assessment tool does not align with gov.uk's interpretation of the Equality Act of 2010. It's got, it doesn't have maternity, pregnancy or maternity leave on it. It conflates, it puts two sections in for the bit that should be race, colour and ethnicity. And it seems we're going to sign important documents off against this, and not having maternity in there, and some of the sexual language doesn't align. Can we change it, please? It's ever so easy to find. Protected characteristics.
Thank you. Any other questions? So, Erica, are we okay to bring this back for final ratification, given the sort of wording changes we've talked about, and Ali wants to have a look at them next month? Does that work okay?
Can do, Chair, and thereafter it's on a quarterly rotation, so you'll not just see the BAF, you'll also see all the high risks, extreme risks that the Trust has as well. So we were planning to bring the risks back in April as well.
Super, thank you. Okay, we'll move on then to clinical negligence scheme for trusts. This is our insurance scheme. Neil, anything you want to pull out?
Yeah, just very briefly, Chair. Thank you very much. Yeah, so this is the NHS self-insurance scheme, contributory scheme. The actuaries project forward what they believe the requirement will be for the sourcing of claims next year. So it's increased by 8.4%. That is included within our tariff uplift, albeit still puts a lot of pressure on organisations. You can see that that the increase is largely, or the funds that make up, contributions that make up, sorry, are largely maternity, but you can see the general contribution is nearly half of that. And if you look further down, we do have a number of areas where claims are going up outside of maternity on an annual basis, and therefore we do need to consider what we ought to be doing as a consequence of that to try and reduce the impact of this on an annual basis. There is the maternity incentive scheme that we previously discussed in prior papers to the board, but I'm recommending that we approve this and contribute to the scheme again this year. Chair, thank you.
Thank you. Just before we do, how much do we spend in total on maternity staff? Do you have that number in your head, Neil?
God, I don't have it in my head, Chair. Sorry, I'd have to look at that.
Justine, sorry. Are you still with us? Yes, you are. Justine, how many midwives do we have, Justine? Justine?
We have 252 midwives currently.
Okay, so my guess is we're spending something like 20 million a year on midwife costs. I'd just like to make a general point, which will get me off some people's Christmas card lists. Wouldn't it be wonderful if, rather than paying very high insurance claims and having to put a lot of money away for those negligence bills, if we just invested more in having more midwives? And we had a period where we invested in having more midwives, getting it right first time, because we have no option really but to sign off this. But the cost just for the midwife element to us is, I think, roughly 40 to 50% of the total wage bill of all the midwives we have. So I would just sort of, hopefully someone will be thinking, when they look at all of the various different reports that have gone into midwifery services, will just take a step back and say, wouldn't it be better, rather than having to pay so much out in insurance, if we just paid out more for having more midwives? With that thought hanging in the air, no action point required. Glenn, anything you wanted to pull out on this?
Yeah, I mean, there has been an investment actually in midwives over the last few years linked to Ockenden, and I think part of the theory of putting CNST premium charges into organisations is to create more of a relationship between monitoring safety issues locally and the cost that the NHS pays out for them, because it is the highest cost specialty in terms of litigation. What I was going to add was that I'm hoping to bring together a bit of a benchmarking report on litigation across the group, so we can just see where we respectively are, to see if there's any opportunity to learn on that.
No, well said, Glenn. And Stephen, your hand went up and went down. Okay, so if you're not happy to sign off on the CNST, could you please raise a digital hand? Okay, thank you very much. Then some items for noting, board. The first is the committee summary reports. The first is from the Quality Governance Committee. Julie, anything you wanted to update us on? Julie, we seem to have lost your sound again. No, we have. We've lost your... Glenn, can you hear Julie? No. Okay, so Julie, we need you desperately to invest in more computer kits.
Okay, is that...
Oh, there you are.
Most things have been covered so far today. I'm having real IT problems today. The one thing I did want to just make sure people were aware of, and I know action's being taken, is that we're nursing patients on Aikenbury Zero, which has very poor or zero facilities for patients. And Sarah's briefed us about that on occasions now, and actually this is not an ideal environment. We talk about corridors, but this ward equally has such few facilities on there that really we shouldn't be other than we're trying to cope with the pressures. And I know everybody knows that, but I think it's credit to the nurses and other staff working in such hard conditions there as well. Everything else we've covered in board. Thank you.
Thank you, Julie, and thank you to those members of staff. Any questions to Julie? Okay, the Audit Committee and Assurance report. Colin, anything you wanted to pull out here?
The only thing to highlight, Chair, is the fact that it's been flagged to us that the head of internal audit opinion is likely not to lead to full assurance. It's likely to be a less than significant assurance, which is unfortunate. That will be reflected in our annual governance statement. There have been a series of issues that the internal auditors have identified, many of which we've actually addressed already, some of which has been covered on today's agenda, some of which we're working on in terms of action plans. But generally speaking, I think this is an area where we do need to give increased focus. So we have fewer limited assurance reports in due course coming through to the through to the Audit and Assurance Committee.
No, thank you, Colin. Any questions or perspectives to Colin? Okay, thank you, Colin, and everyone else on the committee, and then the People and Culture Committee. Carol?
Thank you, Chair. Nothing further to add to what's in the brief summary, but happy to take any questions on those points.
Thank you, Karen, and you'll be taking forward some of the detail we talked about earlier. Any questions or perspectives to Karen? Okay, super. Thank you very much. And then the Financial Recovery Board. Richard, anything you wanted to pull out on this?
Not per se. We spent a lot of time on this morning, but the Financial Recovery Board's been operating since December. It's functioning on a fortnightly basis. It's alternatively chaired by the MD and a NED. Focus has been on sustainable run rate reduction for the year, and it's now shifting into, let's say, the PEP for next year. That's probably the short summary.
Thank you, Richard. Any questions or perspectives to Richard? Okay, thank you. And then we've got committee minutes of the Quality Audit and People and Culture, which I'll take as read unless there are any questions. Okay, we've then got, I think, the Financial Recovery Board terms of reference. Erica?
Thanks, Chair. These are a reissue. They've come back to board, having received comments previously, so coming back for final approval.
Okay, thanks. Any questions on these? Okay, if you're not happy to approve, could you please raise a digital hand? Okay, duly approved. Thank you very much. Any other business from board colleagues? Sue? You're on mute.
Just be trying to get off mute, sorry. Just a very big shout out and thank you to whoever the kind soul is that compiled the acronym list that a lot of us have been asking for. New Year's honour, please, some kind of recommendation, pay rise, whatever.
Well said, Sue. Well done, Erica. And Simon?
I just wonder if we could have an update on where we are with the reception area at the Royal in Worcester, please.
Yeah, I guess the issue here, Simon, is we've got a big desk titled reception, but it's not a reception desk, and nor have we ever taken down the reception signage, so it's an area for confusion. Stephen, are you briefed on this, or do you want to come back to us on this?
Yeah, I can come back to that if that's possible. I think just to give headlines, and to be fair to Scott, who leads our estate, the primary focus we've been giving him at the minute is around car park, and he's been doing an awful lot around that. And hopefully that's coming to fruition. Reception is on there, and there was various business cases that I'm just tracking down and we're going through. So if I can take that as an action and update out of here, that'd be really good.
I think the issue, Stephen, at its simplest was we shouldn't have something called the reception unless it's a reception, or we should ask volunteers to be at the reception as we have at the Alex. It's that type of issue.
Yeah.
So it's sort of one of those irritating things which does cause confusion to patients and families when they arrive. Glenn?
You just said it, Stephen. So could we perhaps have an update on car parking at the next board meeting?
Yeah.
Yep.
Now, we don't want to over-promise and under-deliver, but for members of the staff who may be listening, there is an awful lot of work going on to try and find practical, deliverable solutions on car parking which make a meaningful difference. I cannot thank enough those members of staff who, for example, on the Worcestershire Acute Staff Facebook page, comment on the challenges they have with staff car parking, because it really does help inform us. And I know Stephen runs with his executive colleagues Exec Live, and I would strongly encourage members of staff to dial into those and share with executives the practical challenges they're having. Okay, if there's no any other business, any questions from members of the public? Erica, have any been provided?
No, Chair.
Okay. Thank you. So for members of the public who are with us, any questions you'd like to ask? Okay, I'll therefore draw the meeting to a close. Thank everyone. Say we'll meet again on the 9th of April, which is after Easter. So I wish you a happy Easter in the meanwhile. And for board colleagues, I suggest we meet again at 2:30 for the confidential board. So thank you, everyone. Take care and keep up the great work. Thank you.